Hmm. Okay. Okay. Fine. So, traffic also. These are pressure sore or dendritic ulcer, tissue necrosis and ulceration due to prolonged pressure. There is external pressure more than 30 mm of Hg, blood flow stops, tissue hypoxia occurs, and necrotization and ulcer occurs. It is due to defective blood supply, neurological deficit, anemia, pressure injury, most seen in orthopedic, coma, and stroke patient. So sites have ischial tuberosity, sacrum, heels, head of metatarsals, buttocks, shoulder, and occiput. So features, you have it is painless, non-mobile, punched out ulcer. As is occurred in neurological deficit patient, it is also called as neurogenic or neuropathic ulcer. So investigations, you have study of disadvantage, blood sugar levels, wedge biopsy, and X-ray of the part and spine. You study the discharge, you see the blood sugar level, you do a wedge biopsy, and you see the X-ray of the part and spine. So treatment, it should be treated. Correction of diabetes and anemia should occur. Nutritional supplementation should be provided. Uh, Vacuum assisted closure therapy. Once ulcer granulates, defect is closed with the flap or skin graft, and you have to provide proper care. Change in the position once every 2 hours. Use of water bed or clean bed, and keeping the skin dry and clean. Then you have diabetic ulcer, which is due to increase in glucose in the tissue precipitates infection. Diabetic microangiopathy affects the microcirculation. Increased glycosylated tissue decreases the oxygen utilization. So sites in foot, plantar aspect, leg you have, back you have, sacrum, and perineum you have. So investigations, you have blood sugar estimation, urine ketone bodies, discharge for culture and high sensitivity, X-ray the part to see osteomyelitis, and arterial Doppler of the limb. Doppler you do. X-ray, discharge, urine ketone bodies, and blood sugar. Management, you control diabetes using insulin. There is regular cleaning, debridement, and dressing to be done. Once granulates, ulcer is covered with a skin graft or flaps. Revascularization procedure, you have endarterectomy or balloon angioplasty or arterial bypass graft. You have toe, foot, or leg amputation, and microcellular rubber to prevent injuries. So you take care of your foot. Amputation you do, regular cleaning, debridement, microcellular rubber to prevent injuries. Then you have marginal ulceritis, aggressive ulcerating squamous cell carcinoma presenting in previously traumatized, chronically inflamed, and scarred skin. They are commonly present in context of chronic wound, including burn injury, varicose vein, venous ulcer, ulcers from osteomyelitis, and post-radiotherapy scars. Then you have infectious diseases like tetanus, which is caused by Clostridium tetani. Infective agent is the spore, and the source of infection is soil, manure, and dust. So, mode of transmission is spores gain entry via wounds, pricks, and injuries. So, incubation period between entry of spore and appearance of symptoms is 7 to 10 days. Shorter the incubation period, worse the prognosis. Then period of onset is between appearance of first symptoms and appearance of first sign. So pathogenesis, spores will enter the wound, they germinate in the anaerobic environment, they release bacteria, then they release exotoxins. There are two types of exotoxins, tetanolysin and tetanoplasmin. Tetanolysin causes hemolysis, whereas tetanoplasmin blocks cholinesterase enzyme at anterior horn cell, leading to increase in acetylcholine in synapses, leading to hyperexcitability and reflex spasm along with tonic-clonic seizure. So, toxin is fixed in nerve tissue, cannot be neutralized by antitoxin. So, symptoms due to nerve involvement, you have trigeminal trismus. Facial, you have ricinus sarcoides, which is smiling faces. There is a rigid smile due to spasm of facial muscles. You have zygomatic major also. which is involved. It looks like a patient is smiling. Okay. So desmoplasmin, desmolizin, blocks cholinesterase at antiretroviral, increased ACH, hyperexcitability and reflexspasm across the chronic seizure. Once it is fixed, yeah. Then you have vestibulocochlear, which is hyperacusis, vagus and hypoglossal, which is dysphagia, and respiratory muscle spasm leading to respiratory failure and death. And next we have different positions. You have opisthotonus, where it is backwards, orthotonus, where the back is straight, and emprosthotonus, where it is a forward bulge, and you have pleurotonus, which is lateral bulge. And base on which side bend that muscle. Going on, we have complications of tetanus, which is bone fracture, respiratory failure, carditis, which is life threatening, deep DVR, repeated convulsion can lead to coma, of course. DVR, second. What is DVR? I think it's deep venous reflux, though I'm not sure what it means. Okay, differential diagnosis, of course, right chain poisoning, where the position is normally in between the seizures if it's a right chain poisoning. Metabolic causes like hypocalcemia, hypomagnesemia, hypoglycemia, and convolutional disorders. That's why there is seizures. Seizures are there, bending is there, and trigeminal trismus will be there, facious evidences, sarcoidosis will be there, respiratory muscle spasm will be there, vagus and hypoglossal dyspnea, and hyperacusis in vestibulocochlear. Type of seizure is tonic-clonic seizure. So management, you have isolation, eliminating the source of toxin, neutralizing the circulating toxin, control of muscle spasm, control of autonomic dysfunction, wound management, and active immunization of using tetanus toxide. So isolation, dark white room, supportive critical care, penicillin, clindamycin, erythromycin, human tetanus immunoglobulin, control the seizures with diazepine, phenobarbital. Then you provide fluid therapy, morphine, anticholinergics, alpha-2 agonist, magnesium sulfate, which is a anticonvulsant and vasodilator, and wound management, wound debridement, and plus you have to drain. Active immunization you do with tetanus antitoxide, DT. Then we have pyogenic abscess. It is a localized collection of pus in a cavity lined by granulation tissue covered by pyogenic membrane. Contains pus made of dead WBCs, multiplying bacteria, toxins, and necrotic materials. So bacterial causing abscess is Escherichia pyogenes, E. coli, Pseudomonas, Klebsiella. So precipitating factors precipitating abscess formation, you have nutritional deficiency, diabetes, HIV, immunosuppression, trauma, and road traffic accident. Immunosuppression, nutrition deficiency, HIV, road traffic accident, trauma. Okay. So clinical features, you have fever with chills and rigors, localized, smooth, fluctuating swelling, throbbing pain upon touch, brownie in duration, active ongoing features of inflammation, dolor, color, tremor, and loss of functional loss. And differential diagnosis, it can be aneurysm, soft tissue tumor, hematoma, and cold abscess. So management, you give Hilton's method of drainage. It is used in neck, axilla, and parotid by using Lister sinus forceps under general or regional anesthesia. Clean and drape the person, aspirate the pus. Skin incision is parallel to the neuromuscular bundle. using Pyogenetic membrane opened using blister sinus forceps. Abscess cavity is clear of pus and washed with saline. Wound is not closed, allowed to granulate and heal. Pus is sent for culture and sensitivity. Antibiotics and treatment is the cause. So one thing you should remember is blister sister sinus forceps. Check this out. Okay, then we move on to carbuncle, which is also called as, it is called so because it looks like charcoal. It is infective gangrene of skin and subcutaneous tissue, where the causative agent is SRS. Always it is SRS. Site is more in the nape of neck and back, shoulder, cheek, and hands. Risk factors: you have diabetes, more than 40 years old, male. And pathogenesis: infection occurs, development of small vesicles, red indurated skin with discharge in pus, which leads to vesicles fusing together to form central necrotic ulcer, which is ash gray sign. Skin becomes black due to blockage of cutaneous tissue, and this is spread to adjacent skin rapidly. So investigations: you have urine sugar and urine ketone bodies, you have blood sugar, discharge culture, and sensitivity. Treatment: you have control of diabetes, antibiotics depending upon the sensitivity, drainage and debridement, and wound granulation. Once it granulates, skin grafting is done. Then you have Pott's puffy tumor, which is diffuse external swelling in scalp due to subperiosteal pus and scalp edema. It is a misnomer. It is not a tumor. Site is frontal region caused by chronic fungal sinusitis and trauma, and it has clinical features of pain and boggy swelling in the frontal region. You have pitting scalp edema also. So investigations: you have ESR will be raised, total leukocyte count will be there, and skull X-ray you have to perform. So complications may be osteomyelitis of the frontal bone, intracranial spread of the abscess, and cortical vein thrombosis. Cortical vein thrombosis. Give me a second. Which is cortical vein? Okay, these are the superficial veins of the brain. Okay. Cortical vein thrombosis. Okay. Superficial veins are there, intracranial spread of the abscess will be there, cortical venous thrombosis will be there, and antibiotics can be provided. Excision under general anesthesia and extension into cavity leads to surgical decompression using dandy brain cannula. One second. Drainage and debridement. Antibiotics depending on sensitivity and control the diabetes. Ash grace love is there. Then we move on to gangrene. It is an infective gangrene caused by clostridial organism, aka malignant edema. Causative organisms are Clostridium perfringens, Vellici, Clostridium septicem, Clostridium histolyticum. Source of infection is from soil, dust, manure, and intestine, which is autoinfection. Infective agent is the spores. Mode of transmission is infection of wounds, injuries, and pricks. Spores enter through the devitalized tissue, commonly in road traffic accident. They germinate and they release bacteria, which will multiply, and exotoxins are released, which causes their effects. which gas gangrene malignant edema. It's also called malignant edema. Okay, I didn't know. Okay, then moving on, we have exotoxins, lecithinase, which is extensive myocyte necrosis, hemolysin, hyaluronidase, proteinase. You have those are the exotoxins, lecithinase, which is extensive myositis and necrosis, hemolysis, so RBC is gone, hyaluronidase, rapid spread it allows, and proteinase. Okay, then clinical features, you have signs of fever, tachycardia, features of toxemia, wound with foul smelling discharge, decaying apple odor, crepitus will be felt, jaundice, you have liver involvement, and renal failure is there. So complications, you have septicemia, circulatory failure, disseminated intravascular coagulation, and death. Septicemia will be there, circulatory failure will be there, circulation will not occur, and disseminated intravascular coagulation will occur, and death is commonly seen. Investigations, you have chest x-rays, which is gas in the plane or under the skin can be noticed. Gas in the muscle plane or under the skin will be noticed. Liver function test, partial pressure of oxygen, partial pressure of carbon dioxide you can perform. CT scan is useful in chest or abdominal wounds. Gram stain, you have gram positive bacilli. Robertson cooked meat media will turn pink with sour smell. So prevention of gas gangrene, it is you have to properly debride the devitalized crust wounds. Devitalized wound should not be closed. The wound should not be closed. Adequate, you should be cleaning it with peroxidase adequately, and penicillin should be provided as a prophylaxis. Proper debridement, devitalized wound should not be closed. Adequate washing with hydrogen peroxide and penicillin as prophylaxis. So treatment, you have penicillin is useful if given within 6 hours of infection. You have anti-serum you have to provide. You have hyperbaric oxygen you have. Department of devitalized tissue, and you have severe case you have to do amputation wherein the stump should not be closed, which is skeleton application. Penicillin 6 hours, anti-serum, hyperbaric oxygen, increase oxygen, decrease anaerobicness, debridement of devitalized tissue, department of devitalized prevention, proper debridement. Devitalized one should not be closed. If it is closed, then it becomes an anaerobic condition, so it'll just spread. H2O2, which acts as an antibacterial agent, it just oxidant, it's an oxidant. Penicillin as prophylaxis. One important here is Robertson cooked meat media. This is an anaerobic media. Liver function test, partial pressure of oxygen, partial pressure of carbon dioxide you have to check. X-ray also you can check. Okay, gas in the muscle plane will be there and under the skin will be there. Tachycardia will be there. Fever and tachycardia. 1 degree Celsius rise, you have 10 pulse. Features of toxemia, wound with foul chilling and decaying apple odor will be there. Capitis is felt. Jaundice if liver involvement, renal involvement. Okay. Wounds, injuries, pricks. Okay, moving on, we have necrotizing fasciitis. It is a splitting inflammation of skin, deep fascia, soft tissue with extensive destruction of, and toxemia will be seen. Give me a second. Something is happening with the app. I'll just restart it. Okay, so going on, Muscles are usually not involved in necrotizing fasciitis. They are not involved. Okay, causative agent, you have spiogens, MRSA. Risk factors, you have old age, smoking, diabetes, obesity, and immunosuppression. Site is limbs, lower abdomen, groin, and perineum. So clinical features, you have fever, erythema, edema, blisters and bullae formation, hyperesthesia, crepitus, tissue necrosis, and hemorrhagic bullae can all be seen. So management, you provide IV fluids and blood transfusion, broad spectrum antibiotics you have to give, third generation cephalosporin and aminoglycosides, and pus culture you perform, control the diabetes, hyperbaric oxygen therapy, radical excision of gangrenous tissue, vacuum assisted therapy. So now, necrotizing fasciitis also has polygenic type of mode of infection. Hyperbaric this thing is very much important. So muscles not involved. So there's also types. You have monogenic maybe, and polygenic. They are very important to mention. You have erythema, edema, fever, blisters, and bullae formation, hyperesthesia, process in this. Okay. Do from TB. I have to do this from textbook because this is not adequate. You have to write more. In necrotizing fasciitis especially, there is two types and all. You have to write types of necrotizing fasciitis. You need to write treatment also. You have to provide a lot more in things like only antibiotics, pus culture, hyperbaric oxygen, radical excision of the gangrenous skin, plus regular debridement. They have not written a lot of features. I have read this a lot more. So then Madurai foot is Mycetoma pedis, chronic granulomatous condition of foot, involves the subcutaneous and deeper tissues, causes multiple discharging sinus caused by actinomycosis nocardia or Madurella mycetoma or Madurella gross. Nocardia, actinomycosis, Madurella mycetoma. Okay. Multiple discharging sinus will be there, subcutaneous and deeper tissue it will be affecting, and it's a chronic granulomatous condition. So pathogenesis, organism enters through the prick in the foot, usually in a patient who walks barefoot. It reaches deeper plane in the foot. It evokes chronic granulomatous inflammation. It causes pale, painless, firm nodule. It forms vesicles and bursts to form a discharging sinus. Evokes chronic granulomatous inflammation. Okay. Organism enters through prick in the foot, reaches deeper plane, evokes chronic granulation inflammation, causes pale, painless, firm nodule. It forms vesicles, forms discharging sinuses. So clinical features, you have multiple discharging sinuses. In discharge contains granules which are black, red, and yellow in color. Regional lymph nodes are not involved, and secondary bacterial infection can occur. Osteomyelitis will be there. Regional lymph node because it is a chronic disease. You can remember it as. It's not really the exact cause. black, red, and yellow in the granulation, multiple discharging sinus, of course. Secondary bacterial infection is common, with osteomyelitis also is common. Then investigations, discharging microscopy, branching filaments will appear in the appearance of organism, will be there because it's a fungi. It's a fungi, no? So branching filamentous appearance will be there. Culture in saccharose SPD. Saccharose dextrose agar, I think so. I forget the full name. Let me check once. And SPD. Suboraud. Yes. Suboraud dextrose agar. So X-ray of the foot to look for osteomyelitis, FNAC and biopsy to do confirmation of hemangioma or actinomycetoma, and MRI. You have a dot in circle sign. Okay. So treatment, you have medical treatment, which is actinomycosis. You give cotrimoxazole and streptomycin, and new mycetoma you give ketoconazole and voriconazole. Surgical, you can also do wide excision and amputation in severe refractory case. Next we have AIDS in surgery. Okay, just for precautions around AIDS people. So it is a HIV infection with CD count less than 20,000 cell. Symptoms, you have stage 1 asymptomatic lymphadenopathy more than 6 months. Stage 2 is unexplained weight loss more than 10%, recurrent respiratory tract infections, recurrent dermatological infections will be there. Stage 3 is again unexplained weight loss, unexplained diarrhea, pneumonia, meningitis, candidiasis, ehrlichioplakia, and necrotizing stomatitis. Stage 4 is HIV wasting syndrome. Opportunistic infections will be there: Cryptococcus, Zygomatis, Histoplasmosis, opportunistic bacterial infection, NMD, opportunistic viral infection, TB, and TB you have cryptomegalovirus, simplex virus, Epstein-Barr virus, opportunities plasma parasitic infection, you have toxoplasmosis, cryptosporus, iptosporus. HIV-induced cancer also will be there: Kaposi sarcoma, non-Hodgkin's lymphoma, cervical cancer, and miscellaneously you have HIV encephalopathy, HIV cardiomyopathy, retinopathy. All of these will occur in these stages. And you have mode of transmission, you have sexual intercourse, anal or vaginal, you have needle pricks. Vertical transmission will be there, which is transplacental or breast milk. You have organ transplantation and blood transfusion. All of these are transmission methods. Pathogenesis, it is HIV enveloped in glycoprotein, binds to surface molecule, which is CD4 on T cell and monocyte, macrophages, dendritic cell. HIV enters the cell and replicate using reverse transcriptase enzyme. So CD4 they will come, monocytes, macrophages, dendritic cell, they replicate using reverse transcriptase, and they suppress the T function, leading to suppression of B cell, which leads to immunosuppression. So investigations, you have LSF, which is a screening test, Western blot, which is a diagnostic test, RT-PCR. CD4 count is more than 500,000 is asymptomatic. 2,000 to 5,000 Kaposi sarcoma, candidiasis, microtuberculosis infection. In 50 to 20,000 you have pneumocystis and toxoplasmosis. Less than 50 you have cryptomegalovirus and NTM infection. So treatment, you provide antiviral drugs, which is NRTI, NNRTI, lamivudine, acarbazir, NNRTI, which is nevirapine, and NTRTI is tenofovir, and which is nucleoside reverse transcriptase inhibitor, non-nucleoside reverse transcriptase inhibitor, nucleotide reverse transcriptase inhibitor. You have protease inhibitor, which is indinavir, and you have integrase inhibitor, which is ratigrevir, and you have what do you say? Filamentous inhibitor or something like that. I really don't know. This is a new drug, even I never heard of this. FL. Leave it. Okay. Treatment of opportunistic infection should be done. Treatment of tumor should be done. Anti-CD3 or anti-interleukin 2 after HART. And psychotherapy and counseling should be done. So precaution: be careful while handling needles and blade. Wear double gloves, head mask, apron, and goggles. Properly dispose the needles. Spilled body fluid should be wiped with sodium hypochlorite and glutaraldehyde. OT should be fumigated after surgery to HIV patient. Do not use the OT after HIV patient surgery. Okay. Then moving on, we have erysipelas, which is active spreading inflammation of outer dermis and superficial lymphatics. It is caused by Streptococcus pyogenes. So clinical features, you have welding marketed skin rash, which is rose pink rash. Rose pink rash. And you have cutaneous lymphangitis. So outer dermis is involved, superficial lymphatics is involved. So skin vesicles will occur, which eventually rupture and give out a serous drainage. You also have millions ear sign, which is a clinical sign used to differentiate erysipelas and cellulitis. So skin of earlobe is adherent to the subcutaneous tissue. Cellulitis cannot occur. And erysipelas, being a cutaneous condition, can spread into earlobe. So complications, you have septicemia, localized cutaneous gangrene, necrotizing fasciitis, and glomerulonephritis. So treatment, you have penicillin, clindamycin, roxithromycin. Okay, then you have pyogenic granuloma, which is infection of myrotrauma, leads to formation of unhealthy granulation tissue, which protrude through the wound, also known as acquired lobular capillary hemorrhage. So features, you have single well-defined foam nodule. Site is the face, scalp, fingers, and toes. So differential diagnosis, hemangioma may be there, papilloma may be there, melanoma may be there. So treatment, you have excision and laser surgery. That is pyogenic granuloma, infection of minor wound, unhealthy granulation tissue which protrudes through the wound. It is also known as acquired lobular capillary hemangioma. Single well-defined foam nodule. One single nodule will be there. Scalp, finger, face, toes. Then we have swellings, which is lipoma, also known as universal tumor or ubiquitous tumor, which prevalence is in 2 out of 100 people. It is a benign neoplasm arising from yellow fat. Mode of maturation of adipocyte, made of mature adipocyte, but fat in lipoma is considered unavailable for general metabolism. Fat is not available for general metabolism. So site, it can occur anywhere in the body except the brain. You have subcutaneous and subfacial site, intramuscular and intermuscular sites, parosteal or subsynovial or intraosseous, subperiosteal. You have subserosal and submucosal in GI tract. Epidural, it is never intradural. It's always extradural, it's never intradural. And intraglandular, which is breast, pancreas, and kidneys. These are the lipoma sites. Subcutaneous, subfacial you require, intramuscular, intramuscular, always extradural, subserosal, submucosal in GI tract, subosteal, subsynovial, intraosseous, subperiosteal may be seen them, parosteal also, and intraglandular. Okay, mode of fat in lipoma unavailable. Benign neoplasm from yellow fat. Okay, types, it may be localized, which is encapsulated, diffuse, which is not encapsulated, multiple lipomas associated with Men syndrome, Banyan-Suana syndrome, adiposa dorsa, which is Dercum's disease, multiple lipomatosis, female epileptics and psychiatric patients in the trunk and girdles. This is Dercum's disease. An important question actually is multiple lipomas in Men syndrome, Banyan-Suana syndrome, that you don't really need to remember, but Dercum's disease you have to remember, which is multiple lipomatosis, female epileptic psychiatric patient in trunk and girdles. Okay, next we have hibernoma, which is a benign tumor arising from brown fat, lipoma with non-adipose components. So you have fibrous component, fibrolipoma, telangiectasia, you have nevolipoma, nervous tissue, you have neurolipoma, vessels, you have angiolipoma, cartilage, you have chondrolipoma, and muscle, you have myolipoma. Again, Just keep on writing fibers, fibroneuroderma, all of those things. You can guess on your own. Okay. So malignant transformation of lipoma never happens, as liposarcoma comes from primitive mesenchymal cells, not even from the fat cells. It will come from primitive mesenchymal cells. Okay. So clinical features is localized, lobular, non-tender, non-translaminate. Sorry, not tender. It's not tender. It is localized lobar, localized lobe. Non-translaminate means it's a solid, because it's a solid. It's not a cystic. Pseudofluctuation often feels like fluctuant, but actually not, because fat in body temperature remains soft. You have mobile slip test. Edges of lipoma will slip between the palpating finger. Pain will be there due to dural element or compression of nerves. Investigations, you have ultrasound, CT, MRI, and FNAC. Complications, you have mixed hematous change, saponification, calcification. Treatment is excision under general anesthesia. Yeah, so investigation, ultrasound, CT, MRI, fine needle aspiration cytology. This was for deep or intercavity lipoma. Complications, you have mixed hematous changes, saponification, and calcification. So treatment is excision under local or general anesthesia. I think you cannot see this, but I'm actually writing with my pen and it's not coming out. So I think it's a good time to take a little bit of a break. And anyway, I'm at 23 page number. I have to do till 9600 pages. So we are a fourth of the way done. You can think maybe in another 5 years we can finish off the entire thing. So let's hope that it happens. I'm going to end this for a minute, and I need to finish. I need to finish like 70 more pages. So okay. Let's get this started with. Okay, so I need to obviously finish 70 more pages. First of all, half an hour, 1 hour for 20 pages, 2 hours for 40, and 3 hours for 60 pages. Yeah, I'll cut it close, but honestly, I really do not know what else I can do. I still feel like there's so much left to do. There's so much I didn't do yet. But yeah, let's finish this as fast as possible. Cyst is a collection of fluid in a sac lined by epithelium or endothelium. Okay. Okay, sorry about that. I had to get a sheet of paper because I want to make a list of things which I still need to finish. So first thing which I need to finish is wounds. Process of treatment. That one thing is like a good number of times they ask that question, how will they treat, and in this textbook they haven't really told how the process of wound treatment happens. So I need to do that again. Okay, so then we have necrotizing enteritis also I need to check out once. I could have just wrote here itself. Wound stages of treatment. That one topic which I need to do. Fine, moving on. So cyst is a collection of fluid in the sac lined by epithelium or endothelium. You have types. You have true cyst and a false cyst. True cyst is lined by epithelium and endothelium, but false cyst does not have epithelial lining. It is a pseudocyst of pancreas, apoplectic cyst in the brain as a result of ischemia. So classification, you have congenital, which is dermoid, sequestration dermoid, tubulous dermoid, which is thyroglossal cyst and urotracheal cyst, and you have embryonic remnant cyst, which is mesonephric cyst, and veteronointestinal and duct cyst. You have acquired, which is retention cyst. So acquired is after the bimba. You have Bartholin cyst, parotid cyst, epididymis cyst, and breast and sebaceous cyst. Then you have distension shift cyst, which is lymph cyst and ovarian cyst. You have exudation cyst, which is bursa or hydrocele, and you have implantation dermoid. Something you implied in your subcutaneous, it will become a dermoid. Okay. Distension cyst, retention cyst, exudation cyst, and implantation dermoid. That is the acquired. Congenital, you have dermoids and embryological remnant cyst. Mesonephric cyst, uterointestine cyst. Dermoids, you have sequestration dermoid and tubulodermoids. Sequestration, tubulodermoids. Then cystic tumors, you have ovarian carcinoma, you have traumatic cyst, you have degenerative cyst, and you have parasitic cyst, hydatid cyst, cysticercosis, and trichinosis. So clinical features, they are smooth, fluctuant, and non-tender swelling. They may be single or multiple. Their presentation varies depending on the site. So complication, you have compression of adjacent structures. You have infection. You have Tarzan, which is a Tarzan in ovarian cyst. Okay, and you have calcification in hydatid cyst and cysticercosis, and cachexia, loss of weight. In some cases, infection, Tarzan. Okay, dermoids are congenitally acquired cyst. There are two types. You have sequestration dermoid and you have tubulodermoids. So sequestration, and you have teratodermoids also. Okay, you have three types. You have teratomatous dermoid also. Okay, so sequestration dermoid of epithelium are at line of embryonic fusion, forehead, neck, post-auricular, sublingual dermoid, angular dermoid may be there. You have external angular dermoid over the external angle prices of the frontal bone. Internal angular dermoid is over the root of the nose. Okay, then you have dermoid occurring in skull, main extension into the cranial cavity or orbital cavity. So clinical features, you have painless swelling in the line of embryonic fusion, presence in the second and third decade. Pegget's test will be positive, wherein if you swelling is fixed with two finger and summit yields fluid sensation. Fluid sensation will be there if you press it at the summit. Okay, presence in second and third decade. Painless swelling in the line of embryonic fusion. Reabsorption and indentation of bone will be seen beneath. So investigations, you have chest X-ray and CT of the skull. Complication, you have infection, hemorrhage, rupture, ulceration, and calcification. Treatment, you can exercise under general anesthesia, often raising the intracranial osteocutaneous flap if required. You raise the flap and you excise it. It can ulcerate, calcify, and it can be infection, hemorrhage, and rupture. Tubulodermoids arise from embryonic tubular structure. They are of a few types. You have thyroglossal cyst, ependymal cyst, urachal cyst, and post-anal dermoid also may be there. Post-anal dermoid is a remnant of neuroenteric canal located in front of sacrum and coccyx, and your rectal examination will reveal a cyst. Treatment is complete excision. Coccyx may need to be removed for easy access. And that is the post-anal dermoid, remnant of neuroenteric canal. It located in front of sacrum and coccyx, Rectal examination cyst. Cyst. Then you have teratometastenoid, which is arising from all three layers, ecto, meso, and endoderm, and the site of ovary, testis, retroperitoneum, and mediastinum, contains hair, cartilage, and sebum. Then you have sebaceous cyst, which is a retention cyst due to blockage of duct of sebaceous gland. So it is located in face, scalp, scrotum, and not seen in palm and soles, because there is no sebaceous glands over there. It's a retention cyst. One second. Acquired cyst. It is a retention cyst. Okay. Here only it is there. Sebaceous cyst. It's there here. Okay. You have a Dumodex folliculum, which is a putty-like consistency with parasite in the wall of sebaceous cyst. Okay. Demodex folliculum, you can see. Clinical features: it is a painless, smooth, non-tender swelling, positive Paget cyst. If you press on the, if you hold into and press in the top, it will be positive. It will be fluctuant. Hair over the surface is there due to constant pressure over the root. Hair loss over the surface due to constant pressure over the root. So complication, you have infections and abscess formation. Cox specular tumor, which is a sebaceous cyst ulcerating formation of painful discharging mass. Sebaceous horn is hardening of slowly discharging sebum through the punctum, eyes. It will be coming from the eyes. Treatment, you have dissection method and abscess treatment. So in dissection method, excision through the skin adjacent to the punctum by elliptical incision and initial draining and later excision. Basically excision, but in abscess formation, if it's there, you do initial drainage and then you do excision. Coffee allot spot. These are coffee colored red pigment spots in the skin. Common neuroectodermal origin of nerve sheath and melanocyte located in back, abdomen, and thigh, seen in generalized neurofibromatosis and McCune-Albert syndrome. This is one common thing which is seen in neurofibromatosis. Von Rockenhaus syndrome. And next we go on to ganglion. Ganglions are cystic swelling in relation to tendon sheath or synovial sheath or joint capsule, located in the dorsum of wrist, which is near the scaphoid lunate articulation and around the ankle joint. So pathogenesis, you have cystic degeneration of the tendon sheath. There is leakage of synovial fluid through the joint capsule, and so the joint will be having a capsule. The synovial fluid will be leaking through that. So clinical features, you have smooth, non-tender swelling, transimal illuminant, and it is Paget's test positive. This is ganglion also. It's in relation to tendon sheath, synovial sheath, joint capsule, dorsum of wrist. Near scaphoid lunate articulation, around ankle joint. This is a cystic degeneration. There is leakage of synovial fluid through joint capsule. Treatment, you have aspiration and sclerosant injection, excision done under local anesthesia. Solution. Excision under local anesthesia. Globus tumor arises from succulent Howard's canal. It is a site where the tortuous arteriole communicates directly with the venule and is covered by network of small nerves and is therefore very much painful. So contents, you have angiomyeloma, myeloneuroma, you have blood spaces, muscle fibers derived from arteriolar wall and cuboidal glomus cells. So features, you have severe burning sensation and pain. Most common site is in the nail blade subungual region. Reddish hue spot does not blanch on percussion. This is the globus tumor. Reddish hue spot does not blanch on percussion. Treatment is excision. Then you move on to Baker's cyst, which is a cystic swelling containing gel-like fluid in the lower midline of popliteal fossa. It is a pulsation or pressure diverticula of synovial membrane through an opening in the joint capsule. Clinical features: you have smooth, tender swelling located below the joint line. On flexion, the swelling will disappear. On extension, swelling will increase in size. And pain and tenderness in the knee joint is noticed. Effusion will be there with positive patellar sign, and X-ray will show arthritis changes. So complication, you have rupture which results in sudden pain mimicking DVT. Management is treatment of arthritis, and Baker's cyst is excised in prone position under general anesthesia. It is a swelling containing gel-like fluid in the lower midline of popliteal fossa, and it is a pulsion or pressure diverticula through an opening in the joint capsule. Clinical features: here smooth, tender swelling. Flexion, it will disappear. Extension, it will appear. And small pain and tenderness in the knee joint will be there. Positive patellar sign. Patella will appear. If you can press the patella, I think that's it. Effusion will be there. Okay. And arthritis changes will be there. Rupture will DVT. Sun pain it will be mimicking. And management is treatment of arthritis. Baker's cyst is excised in prone position under general anesthesia. Okay. Then you have transilluminant swelling, which is hydrocele, ranula, epididymal cyst, meningocele, cystic hygroma, and lymphatic cyst. Study this. Ependymal, hemocele, all of this you remember a little bit. Okay, then you move on to electrolyte and nutrition. It is indications of nutrition support. You have preoperative nutrition depletion, postoperative complication, ileitis, ileus, and fistula. Intestinal fistula, anorexia nervosa, intractable vomiting trauma, multiple fractures, massive bowel resection causing small bowel syndrome. All of them will require nutritional support in the form of total parenteral nutrition. All nutrients are required through intravenous route, given through central catheter, subclavian or internal jugular vein, and peripheral vein, peripherally inserted central venous catheter. Central catheter, subclavian or internal jugular vein. Okay. Indication is contraindication of nutrition, high output abdominal fistula, major abdominal surgery, multiple trauma, short bowel syndrome, massive GI bleeding, hyperemesis gravidarum, risk of aspiration, and multi-organ failure, severe burns. So goals is to prevent adverse effect, increase protein synthesis, prevent weight loss, support metabolism, improve immune function, maintain glucose reserve for energy, and maintain acid and base electrolyte metabolism. So complication, you have technical air embolism may occur, catheter displacement will occur, and thrombosis may be occurring. Biochemical, you may have electrolyte imbalance and hyperosmolality. Others, you have dermatitis and staphylococcus infection. So contraindication of total parenteral nutrition, you have cardiac failure, blood dyskaryosis, and altered fat metabolism may be seen. And we move on to hyponatremia, where the sodium levels is less than 135 milliequivalents per liter, and severe hyponatremia may be seen where it is less than 100 milliequivalents per liter. Contraindication is cardiac failure, blood dyskaryosis, and altered fat metabolism. These are the contraindication. Okay. Sodium hyponatremia may be sodium hyponatremia is less than 135, severe is less than 100. It may be of two types: acute, chronic, hypovolemic hyponatremia, hypervolemic hyponatremia, normovolemic hyponatremia, and pseudo hyponatremia. These are the 6 types. Okay. Acute generally presents with neurological deficit. Chronic leads to pontine myelinolysis, behavior changes, progressive weakness, cranial nerve palsies. Hypovolemic hyponatremia is rapid absorption of fluid into intravascular compartment, leads to pulmonary and cerebral edema. Decreased osmolarity causes extracellular fluid to move into the cell. Osmolarity decreases, extracellular fluid moves into the cell. It is corrected by fluid restriction, hypotonic saline, and loop diuretics. Overcorrection or rapid correction of condition can cause irreversible pontine myelinolysis. So hypovolemic hyponatremia is loss of fluid or electrolytes, diarrhea, vomiting. Treatment is isotonic, normal, saline. Causes is symptoms of inappropriate ADH secretion, SIADH, and renal failure. And treatment you provide vasopressin agonist like cycline, demiclocycline. Vasopressin antagonist. Okay. And pseudohyponatremia, you have pulmonary osmolality is maintained by sodium but also by solutes like glucose, plasma protein, and urea. Pathology increases in concentration of solute, proportionally decreases the concentration of sodium. So clinical features, you have dry tongue, sunken eyes, dry wrinkled skin. You have hypotension, dark scanty urine, irritability, disorientation, convulsion, chronic hyponatremia, hypothermia, and reduced tendon reflexes. Chronic hyponatremia, hypothermia, reduced tendon reflexes, irritability, disorientation, convulsions. Hypotension, dark scanty urine, dry tongue, sunken eyes, wrinkled skin. Okay. Hypernatremia. We move on to hypernatremia. Hypernatremia is serum sodium more than 145. Great. That's it. Treatment they haven't provided. Pseudo hypernatremia once again. Plasma osmolality is not only by sodium but these things. Pathology increases the concentration of solutes, proportionally decreases the concentration of is that so? Okay. Then hyponatremia, we of course have sodium excessive, which is more than 145 milliequivalents per liter. Excess infusion of normal saline causes overload in circulating salts and water. It is caused by renal dysfunction and SAIDS induced, central diabetes insipidus, decreased fluid intake, osmotic diuresis, and corticosteroids. So you have types. You have euvolemic hyponatremia, failure of water intake, comatose, bedridden patient with or post-operative patient. You provide if you give due to failure of water intake, high fever if extra renal loss of water is there, and diabetes insipidus. They have excessive loss of water, ADH. Hypovolemic hypernatremia is loss of water, sodium. More water is lost than sodium. So vomiting, diarrhea, excessive sweating, osmotic diuresis by mannitol. Same thing happened here also. 110 minus what do you say? Once again, loss of fluid electrolytes, diarrhea, vomiting, excessive. More water is lost however than sodium. Then it is this thing, hypovolemic hyponatremia. Euvolemic will be failure of water intake, volume will be normal, but high fever, renal loss of extra renal loss of water may be there. Diabetes insipidus, but volume level will be normal. Hypovolemic hypervolemic hyponatremia is gain of water and sodium. More sodium is gained than water. Sodium bicarbonate, hypertonic saline infusion more than 0.9. Then you have clinical features. You have pitting edema, facial puffiness, increased urination, dilated veins, and pulmonary edema. Management is sodium restriction. Treatment of pulmonary edema, hyponatremia should be corrected as slowly as follows. Initial infusion of normal saline, infusion of half strength normal saline, infusion of 5% dextrose. Gradual controlled correction is done, otherwise cerebral edema and hyperglycemia may develop. So you first of all restrict the sodium, treat the pulmonary edema. You have to treat hyponatremia corrected as normal saline 0.75, then 5% dextrose, gradual control correction. Then hypokalemia, which is serum potassium less than 3.5 milliequivalent. Sudden hypokalemia, diabetic coma treated by insulin. Diabetic coma treated by insulin is a very important cause of sudden hypokalemia. Gradual hypokalemia is diarrhea, pyloric stenosis, drugs like beta block agonist, and metabolic alkalosis. Then clinical features, you have slurred speech, muscle hypotonia, which is a physical sign, paralytic ileus, which depresses reflexes, cardiac arrhythmia, and you have QT prolongation, ST depression, and T wave invasion and prominent UA. Hypokalemia, do this, do this, do this, and do this. Okay, this what happens. Hypokalemic alkalosis occurs. Muscle hypotonia, slurred speech, paralytic ileus, depressed reflexes. Okay. Treatment is either oral or IV KCl infusion. Potassium chloride infusion. Hypokalemia is sodium potassium more than 6 milliequivalent per liter caused by renal failure. Renal infusion of potassium, diabetic ketoacidosis, insulin deficiency, metabolic acidosis, tissue destruction, crush injury, tumor necrosis, burns, and potassium sparing diuretics. So management is by ECG. You have twin peak T wave. IV glucose and insulin can be provided. IV calcium gluconate, cardioprotection can be provided. Loop diuretics and continuous ECG monitoring can also be done. Then you have metabolic alkalosis. Hyperkalemia is renal failure, rapid infusion and potassium, diabetic ketoacidosis, insulin deficiency, metabolic acidosis, tissue destruction, burns, crush injury, tumor necrosis, and potassium sparing diuretics. Potassium sparing diuretics is okay. Rapid infusion, renal failure, diabetic ketoacidosis generally increases the potassium levels. Management, you have twin peak sign, a peak T wave. Sinusoidal sign also will be having. You have sinusoidal waves. Sinusoidal ECG. Peak T wave. Whereas here it is depressed, here the T wave will be peaking. QRS decreases. Wait, not QRS. QT length might decrease. Okay. There is increased heart rate. Okay. And metabolic alkalosis, sodium bicarbonate more than 27 millimole per liter. It is due to base excess. It is caused by repeated vomiting seen in pyloric stenosis, hypokalemic alkalosis, excessive alkaline injection like antacids, and cortisol excess. And you have features of Kyle-Stokes breathing with period of apnea for 5 to 30 seconds. Tetany due to alkalosis. So treatment is IV potassium per infusion, and pH is 7.7. More than 7.7 is life-threatening. Immediate correction by IV ammonium chloride. IV ammonium chloride is very much important. So it is potassium infusion. You have to provide metabolic alkalosis. Kyle-Stokes breathing, tetany. due to base excess, repeated vomiting, alkali injection, example antacid, drugs or cortisol excess. This strokes breathing, apnea of 5 seconds, 30 to. Okay, then moving on, we have metabolic acidosis. So metabolic acidosis is sodium bicarbonate less than 21 millimole per liter due to excess acid or base deficit caused by increased in fixed acid. You have diabetic ketoacidosis, starvation, hypoxia, excessive exercising, and you have intestinal strangulation. Here the anion gap is also increased. Loss of base, you have diarrhea, intestinal fistula, and ureterosigmoidoscopy, which is hyperchloremic hypokalemic acidosis. And intestinal strangulation, anion gap is increased, excessive exercise also. There is increase in fixed acid. Diabetic ketoacidosis, starvation, hypoxia. Loss of base is seen in diarrhea, intestinal fistula. So clinical features, okay, basically bicarbonate is less than 21 millimole per liter and it is due to excess acid or base deficit. Clinical features, you have Kussmaul's breathing, rapid breathe, nosy breathing, and tachycardia, cardiac arrhythmia, anorexia, pH is less than 7.2 is life-threatening. Treatment, you have correction of hypoxia, you have IV sodium bicarbonate infusion, treatment of lactic acidosis, treatment of diabetic ketoacidosis. IV sodium bicarbonate, lactic acidosis, diabetic ketoacidosis. Gastrostomy procedure for tube is passed into the stomach abdominally for the purpose of enteral feeding. Indicated in severe malnutrition, major surgeries, major trauma. Contraindicated against in previous gastric surgeries and intestinal obstruction. Problems in gastrostomy tube, you have leakage, infection and displacement and blockage of tubes. Tube passed into stomach abdominally. Purpose of enteral feeding. Indicated in severe malnutrition, major surgeries, major trauma. Contraindicated in previously gastric surgeries and intestinal obstruction. Problems, you have leakage, infection and displacement, blockage of the tube. Then we move on to shock. It is a state of cellular and tissue hypoxia with circulatory failure and poor perfusion and reduced oxygen delivery or poor oxygen utilization or increased oxygen consumption. So it is caused by hypovolemic shock. There is reduction in total blood volume, hemorrhage, severe burns, vomiting and diarrhea. And you have cardiac shock, hypovolemic shock, cardiac shock, septic shock, neurological or esophageal shock, anaphylactic shock, respiratory causes and other causes may be seen. So hypovolemic shock, you have reduction in blood volume, hemorrhage may be severe burns, vomiting and diarrhea. Cardiac shock is acute MI, acute carditis, acute pulmonary embolism, drug induced cardiac tamponade and trauma to the heart. Septic shock is bacterial infection with release of toxins into the circulatory system, and neurogenic is due to anxious stimuli causing severe spasmodic vessel vasodilation. Patient goes into a cardiac arrest and recovers spontaneously. Spinal cord injury, anesthesia can cause neurogenic shock. So anaphylactic shock, you have type 1 hypersensitivity reaction. So respiratory causes, you have atelectasis, thoracic injury and tension pneumothorax. Other causes include acute adrenal insufficiency like Addison's and myxedema. So pathophysiology of shock of any cause of shock, you have low cardiac output, decreased renal blood flow, increased GFR, which decreases the urine flow, activation of RAS, which leads to angiotensin II, aldosterone mediated vasoconstriction and salt water retention respectively. And ADH is released and further retention of water will occur. Then persistence of shock leads to further decrease in cardiac output. Hypoxia leads to metabolic acidosis, release of cardiac depressants is seen and cardiac failure is also seen. And You also have hypoxia, which leads to anaerobic metabolism, lactic acidosis, cell wall damage is seen, sodium and calcium enter the cell, potassium leaks out of the cell, hyperkalemia, hyponatremia, hypocalcemia. Increase in K plus, because K plus leaks out of the cell, sodium and calcium enter the cell. Therefore, serum increase K plus, decrease Na plus Ca plus 2. Extracellular will become intracellular, intracellular will become extracellular because cell wall damage. And yeah, this leads to intracellular lysosomal breakdown, which leads to release of proteolytic enzymes. Low cardiac output leads to decreased blood renal flow, leads to decreased GFR and increase in urine output, activation of RAOs, ADH is released, retention of water is happening. If shock and if shock still persists, there is further decrease leading to hypoxia. Metabolic acidosis, cardiac depressants, cardiac failure. Then you have sickle cell syndrome, which is platelets are activated from small clots at many sites. Disseminated intravascular coagulation, consumption, coagulopathy will occur. There is further bleeding and stages of shock will be there. Factors like infection, trauma, burns, hemorrhage, and hypovolemia will influence hypoxia and its effects. There is, these people do not, they just end it there. This is how the sickle cell syndrome occurs. Proteolytic enzyme, if it is released, it is sickle cell syndrome. Intracellular lysosomal breakdown. Platelets are activated, disseminated intravascular coagulation will occur, further bleeding will be there, and yeah. That's it. Stages of shock. Okay. Hypoxia and effects also can be seen. Then you have severe systemic inflammatory response syndrome. Due to vasodilation, there is severe vascular permeability, thrombosis, leukocyte migration. It leads to microvascular occlusion, cellular dysfunction, DIC, and sickle cell syndrome. You have multi-organ dysfunction syndrome of lungs, kidney, liver, and brain. So, effect of shock, you have its effect on heart, lung, metabolic, cellular changes, brain, and kidney and blood. Investigations have monitoring of and estimation of. Okay, so effect of shock, you have low cardiac output leading to hypertension and reflex tachycardia. Persistent shock will lead to release of cardiac depressants and cardiac failure. Persistent shock, hypoxia, release of cardiac depressants and cardiac failure. Then lung, you have edema leading to decreased gas exchange leading to tachypnea and acute respiratory distress syndrome. Metabolic, you have hypoxia, induced lactic acidosis, and ADH, induced water retention. Then cellular changes, you have lysosomal enzymes mediated destruction of cell. Enzyme mediated, sickle cell syndrome. So brain, you have decreased blood perfusion leads to loss of consciousness. Brain is the last organ to get under perfused in a shock, so it is kind of safe. And kidney reduced GFR, RAS mediated water and salt retention, disseminated intravascular in case of blood. Okay, cardiac failure in heart, and acute respiratory distress syndrome due to tachypnea. So investigations, you monitor BP, pulse, heart rate, respiratory rate, urine output, central venous pressure, and pulmonary capillary bed pressure, and estimate pH, lactate level, see blood creatinine, prothrombin time, activated thromboplastin time, and arterial blood gas analysis. You have to estimate. Okay, so moving on, you have treatment. Treatment is by acute critical care management by assessment and resuscitation of ABCDE, disability and drugs and exposure in AE. Fluid replacement, syringal lactate, Hartmann solution, plasma expander, hematocele. This is important. Blood transfusion. Hematocele. Blood infusion. Inotropic agents, you have epinephrine for anaphylactic, norepinephrine for vasodilatory septic shock, and dobutamine for cardiogenic shock. Acidosis collection, you have IV sodium bicarbonate, you have steroid hydrocortisone, improves perfusion, decrease systemic inflammatory effects. Then you have hemodialysis, pain control, which is morphine 4 mg IV, ventilator and ICU care management is there, and MAST, you have military anti-shock trouser, which provides circumference external pressure of 40 mm of Hg wrapped around lower limbs and abdomen, inflated with required pressure, redistributes the blood and fluid towards the center. Then we have septic shock, widespread infection and toxin causing multi-organ failure and dangerously low blood pressure. So pathogenesis, toxin from bacteria, virus and parasite, inflammation, activation of macrophages, neutrophil monocytes, release of cytokine and free radicals. Then you have severe inflammatory response syndrome, and wherein you have reversible hypodynamic state, circulatory failure with MODS with DAC, and in irreversible hypodynamic cold stage of septic shock. Okay, so stages of septic shock, you have hypodynamic and you have hypodynamic. Hyperdynamic warm stage, hypodynamic hypovolemic stage, which is the cold stage. So warm stage is a reversible stage, fever, tachypnea, tachycardia. Pyogenic response is intact, and treatment is antibiotic, drainage of pus, laparotomy for peritonitis, and ventilator support. Hypodynamic hypovolemic treatment. Wait 1 second. Ventilator and ICU management. Morphine you provide. Okay. Hemodialysis, steroid hydrocortisone improves perfusion, increases systemic inflammatory response. Sodium bicarbonate, inotropics, blood transfusion, fluid replacement, ABCD, fluid transfusion, epinephrine, norepinephrine, and dobutamine, cardiogenic shock. Okay. IV sodium bicarbonate for acidosis, steroid, which improves perfusion, decreases SI. Morphine also okay for pain, and ICU masked pressure. Okay. Septic shock, you provide ventilator support. Okay. Septic shock, hypodynamic, antibiotics, underlying cause, drainage of pus, ventilator support. Okay. Then in hypodynamic hypovolemic state, the pyogenic response is lost. Patient is in decompensated state. Irreversible shock leads to multi-organ dysfunction syndrome. So treatment of septic shock, you have correction of fluid and electrolyte balance, blood transfusion, blood perfusion is most important. You have appropriate antibiotics to be provided. You treat the underlying cause. You have drainage of abscess, laparotomy for peritonitis, dissection of gangrenous bowel, and wound excision. So you can also have a norepinephrine, which is the drug of choice for septic shock, and high dose steroidal therapy, which is counteracting the effects of toxemia. Norepinephrine is the drug of choice. Wound excision, gangrenous bowel resection, laparotomy, and drainage of abscess. Okay. Next, we move on to hyperbaric oxygen. Administration of oxygen 1 or 2 atmosphere in a compression chamber. It increases arterial oxygen saturation and increases oxygen perfusion to the tissue. Indicated in carbon monoxide poisoning, tetanus, gas gangrene, bed sore, frostbite, necrotizing fasciitis, and as a radiosensitizer in treatment of cancer and Caisson's disease. So complications, you have cerebral gas embolism, tympanic membrane rupture, visual defects will be there, oxygen toxicity will be there, and respiratory depression will be there. Contraindication, it is seen in asthma, emphysema, and pregnancy. You should not give in asthma and pregnancy. Cerebral gas embolism, tympanic membrane rupture, that's why it's not given in pregnancy. Visual effects, toxicity, respiratory depression. Carbon monoxide poisoning, you have to give tetanus, you understand, because that is difficulty to breathe it. Gas gangrene also to increase the oxidation. Frostbite, necrotizing, same thing. Radiosensitizer, it acts as a radiosensitizer, and Cassie's disease is acute decompression disease. So whenever you have a Cassian's disease, you have to provide the hyperbaric oxygen. Then hemorrhage and blood transfusion is there. Complications of blood transfusion, you have febrile reaction due to pyogens in blood or in the infusion set. You have fever, chills, tachycardia, allergic reaction, you have urticaria and allergy to allergens in the donor plasma. You have acute hemolytic reaction due to ABO incompatibility. Hemoglobinemia, hemoglobinuria, like a smoky urine you can see. Then you have jaundice and dyspnea, acute renal failure, and DIC. Transfusion related acute injuries also may be there, and you have donor plasma antibodies against HLA and leukocyte. Against HLA and leukocyte specific antigen. Okay, and breathlessness, hypertension, saturation drop will be there, and X-ray you'll be seeing bilateral diffuse infiltrates. So then transfusion mediated graft versus host reaction, you can see it is recognition and reaction against a recipient tissue by donor plasma antigen seen in immunosuppressed and leukemic patients. So it features pancytopenia. Toxic epidermal necrolysis, and liver dysfunction. Okay, so these are all blood disorders. Congestive cardiac failure, transmission of infection, thrombophlebitis, air embolism, coagulation failure, wherein you have due to dilatation of clotting factors, electrolyte imbalance, iron overload, and citrate toxicity, which causes bradycardia and hypocalcemia. Okay, so going on back. Complications of blood transfusion. You have febrile reaction will be there. Pyogens in the blood and transfusion set also will be there. So fever, chills, tachycardia will occur. Allergic reaction, you have urticaria and allergy. And acute hemolytic reaction in incompatibility. You'll be having smoky urine, jaundice, dyspnea, acute renal failure, and DIC. Transfusion related acute injury. You have donor plasma antibodies against HLA and leukocyte specific antigen of recipient. X-ray of the bilateral diffuse lung infiltrates, you can check. Breathlessness, hypertension, and saturation drop is noticed. Transfusion versus graft, transfusion related graft versus host disease by donor's plasma antibodies. It is seen in immunosuppressed and leukemic patient. It features pancytopenia, toxic epidermal necrolysis, and liver dysfunction. You have congestive cardiac failure, transmission of infection, thrombophlebitis, air embolism, coagulation failure, severe electrolyte imbalance, iron overload, and bradycardia and hypocalcemia. Then you have massive blood transfusion. Is when transfusion equivalent to blood volume loss in less than 24 hours. Adults, if it is more than 5 to 6 liters, and infants, if it's 85 ml per kg body weight. If it's more than that, then it is massive blood transfusion is required. Single transfusion more than 2.5 liters is given continuously. Transfusion of more than 4 units in 1 hour, and transfusion of more than 50% of the blood volume. If it is done, it is massive blood transfusion. It is indicated in severe trauma with liver, cardiac, pulmonary, pelvis injury, and during surgical bleeding. Primary hemorrhage on the table. Adverse effects is the same as above. All of these transfusion related hemolytic reaction, jaundice, dyspnea will be there, renal failure will be there, allergic reaction, febrile reaction will be there, chill fever, acute injury, HLA specific antigen, of course, X-ray bilateral diffuse infiltrates, lung infiltrates will be seen, and related graft was also immunosuppressed leukemic patient and all, pancytopenia will be there, toxic epidermal necrosis, and liver dysfunction. Against recipient donor plasma antibodies. Congestive cardiac failure, transition infection, thrombophlebitis, hair embolism, coagulation failure, severe electrolyte imbalance. Okay. Massive blood transfusion is when 5 to 6 liters, 85 ml per kg body weight. More than 4 volume, more than 50% volume. Severe it is pelvic injuries, okay. Auto transfusion, which is autologous blood transfusion. Healthy individuals with no infection and hematocrit more than 30% can pre-donate blood few weeks prior to any elective surgeries. It can be used in time of surgery. Autologous blood used in orthopedic surgery, gynecological surgery, and urologic surgery. Patient donates 1 unit of blood weekly. Last donation should be 48 hours before the date of this surgery. This is auto transfusion. 72 hours, 1 unit weekly you can give before that. Okay. Blood substituents. This is a very important question. Honestly, I'm going to revise this again because this is such a shitty ass question, man. Give me a second. I want to take a photo of this and send it to somewhere. Here. Okay, I just sent them. So let me just set up the thing again. Honestly, my phone is burning up, but I genuinely have every plan of replacing my phone, so the setup I'm using right now is kind of scuffed. Screensaver off, and yeah, let's continue with red cell substituents, which is red cell substituents and plasma substituents. Yeah, perfluorocarbon, which is abiotic RBC substituent, which is a synthetic perfluorocarbon, synthetic oxygen carrier, half-life of 7 days, high affinity for oxygen, inert, colorless, biocompatible fluid. Then you have stromatophyll hemoglobin, which is biomimetic hemoglobin substituent, high affinity for oxygen, does not contain 2,3 dopicrogel. I think that's how you spell it. Dopicrogel, basically. Chelates with a reversible bound oxygen. Intraoperative salvage of blood is seen, and on table, blood is collected, watched, filtered, and transfused. Chelates with reverse bound oxygen. It is intraoperative salvage of blood. You take the salvage from which of blood, On table blood is collected, washed, filtered, and it is again transfused again. Stroma free hemoglobin, biomimetic. Perfluorocarbon is aortic RBC substituent, synthetic oxygen carrier. Okay, inert colorless biocompatible fluid. Stroma free hemoglobin, you have biomimetic hemoglobin substituent, high affinity for oxygen, does not contain 2,3 dopamine. And plasma substituents, you have human albumin plasma. 1 gram of albumin binds with 14 ml of water, increases the blood volume. Indicated in cirrhosis, burns, nephrotic syndrome, and ovarian hyperstimulation syndrome. Then you have dextrans, which is used to improve plasma volume. Disadvantages: it interferes with Redox formation and interferes with platelet formation. It causes hyperchloremic acidosis and pontine myelinolysis. Pontine myelinolysis is caused by another thing which we just read, which was very early on we read, no? Hypovolemic gas nutrition, sodium. So rapid correction can lead to irreversible pontine myelinolysis. Chronic hyponatremia also leads to myelinolysis. Okay, pontine similar to decrease in Na plus. Then you have gelatin, which will form hematocele, which is plasma expander, and hydroxyethyl starch. Okay, those are all the things which you need to remember. Then hemorrhage classification. Have we reached 1 hour point? Okay, so burns and definitive treatment. And okay, we have reached almost halfway point. So I'll stop at the halfway point. I'll eat something. Wait. Shit. I shouldn't do that. Okay. Hemorrhage classification, you have in detention to operative procedure, you have primary, which occurs at the time of injury or operation. Reactionary is less than 24 hours after surgery. Precipitating factors: coughing, straining, rise in BP, slipping of ligature, ligature, man, what is this? Ligature. Autocorrect for those people. And clot dislodgement. Primary at the time of injury or operation. Second, reactionary less than 24 hours. Precipitating factors, you have coughing, straining, rise in BP, slipping of ligature, and clot dislodgement. Commonly occurs after major abdominal surgery, circumcision, hydrocele surgery, tonsillectomy, thyroid surgery, and cholecystectomy. Secondary, it occurs after less than 14 hours after surgery, precipitated by infection, pressure. Commonly occurs after hemorrhoidectomy and inguinal block dissection. So indications, you have acute blood loss, more than 15% blood volume is lost during major surgery, burns, prophylactic measure prior to surgery due to anemia, immune thrombocytic purpura, and hemophilia. All of these are indication for the blood transfusion. ITP. Burns is injury to skin or other organs, primarily caused by heat or due to radiation, radioactivity, electricity, friction, or contact with chemicals. Classification is based on severity. We have mild, moderate, and severe. Mild, you have partial thickness burns, less than 15%, less than 10% in children, and full thickness burns is less than 2%. Okay, then moderate, you have second degree, 15 to 25% burns. Third degree in 2 to 10% burns. Burns not involving eyes, ears, face, hand, feet, and perineum. That is moderate. And severe, you have second degree burns more than 25%. Third degree in more than 10%. Burns involving eyes, feet, perineum, face, all those things. And burns with fractures are major mechanical trauma. partial thickness bone 10%, 15% less than 15%, less than 10%. Full thickness less than 2%. Okay, degree of burns is more important. This more than this severity. Degree classification based on thickness of skin involved. So first degree is red and painful epidermis. No blisters, heals within 7 days by epithelialization without scarring. It shows capillary filling. Second degree is red, painful, mottled area is there with blisters. Whereas here there is no blisters, here there is with blisters. Sensation is present by but no blanching is seen. You heal by 14 days by epithelialization. Superficial second degree burn heals with pigmentation. Deep second degree burn heals with pigmentation and scarring. Then you have third degree burns, which is painless, charred, affected areas. Charred, denatured area is called as eschar, and wound must be healed by re-epithelialization from the wound edge. Then fourth degree involves underlying tissue, which is bones and muscles and bones. Okay, just a second. So honestly, I finished a good chunk of topics. All of these topics also I've done quite a big chunk of it, but I haven't been able to do breast and parathyroid and a few salivary. So before I finish, I'll do this and I'll go directly up to breast, and I'll go backwards from breast, and I'll do neuro also. I'll do deep ischemia. All of this I've done a lot. I've done a lot of these topics a lot of times. Gangrene also I've done a lot. I'll do limb, venous thromboembolism I have to do. Yeah, if you should know all this, okay. Varicose vein is one important thing which I want to do from textbook. Varicose vein, if you do from here, it's really not worth it. Nephrotics I'll do. Skin tumors I'll have to do. Okay. Yeah. Oral cavity is very difficult. And pleomorphic adenoma, Wathrein's tumor, yes. Breast carcinoma is a major problem here. Leaving that, all of these other like hand and stuff, they don't ask that much. They do ask, but you need to remember only the important headings. Okay, so classification based on thickness of skin involved. This is the second type. Partial thickness burn, full thickness burn. Partial thickness is either first or second degree burns. Red painful, often with blisters, and full thickness is third burns. Charred, insensitive, involves all layers of the skin. So Wallace's rule of 9, which is early assessment of burn severity, is taught here. Pathophysiology, heat causes coagulative necrosis of skin and subcutaneous tissue. Vasoactive peptides is released, altered permeable cavity, capillary permeability, loss of fluid leading to severe hypovolemia, leading to decreased myocardial function, leading to decreased cardiac output and decreased myocardial function, decreased renal output leading to oliguria, renal failure. Altered pulmonary resistance causes pulmonary edema, which infection leads to severe systemic inflammatory response and multi-organ failure. All of this is the pathophysiology. Coagulative necrosis of skin. From all of that, severe hypovolemia will occur, decreased cardiac output, pulmonary edema, renal blood flow, oliguria, decreased myocardial function. Before I go, okay, I need to revise this again. So first degree there is no blister, second degree there is blister, and third degree there is charred denuded area called eschar. There's no blister, there's eschar, and 4th degree involves muscles and bone. Mm, First degree is red painful, second degree is painful, mortared area, red, and third degree is painless, charred area. Okay, then first degree wound heals by epithelialization without scarring, which is epithelialization without scarring. Second degree sensation is present but heals in 14 days by heals by 14 days heals by 14 days by epithelialization. You have superficial and deep. Superficial heals with pigmentation and deep heals with pigmentation and scarring. Re-epithelialization from wound edge occurs and involves the underlying tissue. Okay. Based on thickness of skin involved, you have partial thickness burn, full thickness burn. Partial thickness is either first or second degree burn, red and painful with blisters, and full thickness is third degree, charred insensitive skin. While a rule of 9 is for sensitivity. Okay. Then clinical features, you have history of burns is there, pain, tachycardia, tachypnea, fluid loss is there, shock is there, metabolic acidosis is there. Post-burn sequel or complication, you have massive edema, cardiac dysfunction, renal changes, pulmonary changes, GIT changes, electrical injuries can cause fracture and convulsion. Eschar may compress underlying vessel. Post-burn immunosuppression leads to severe opportunistic infections. So again, going back, there is loss of protein, decreased plasma oncotic pressure, loss of fluid from intravascular fluids, release of cardiac depressant, cardiac failure we've seen, renal failure, ADH release, water retention is there, aldosterone release, sodium retention is there, toxin and myoglobin causes acute tubular necrosis. Acute tubular necrosis is common. Then altered ventilation perforation ratio is seen, pulmonary edema and acute respiratory distress syndrome is there in burns. Okay. GIT, paraticus, acute pancreatitis, curling saucer can be seen. Acute gastric erosion resulting as a complication from severe burns when reduced plasma volume leads to ischemia and cell necrosis lying off gastric mucosa. Decreased mucosal defense not due to increased HCl. Then we move on to sepsis in a burns patient. Can occur via burns forceps, catheter site, and central venous pressure line. So precipitating factors, you have loss of proteins and immunoglobulins, you have loss of physiological barrier which is skin. Causative agents, you have streptococcus, staphylococcus, pseudomonas and candida. Management, first aid, the clothing should be removed, cool the part with curling water for 20 minutes, clean the part to remove dust, mud, etc. Chemoprophylaxis, you have tetanus toxide and local antiseptics, you cover with dressing and you provide sedation. Comfort with sedation. Definitive treatment, you have maintain airway breathing ABC circulation, endotracheal intubation, assess percentage, degree and type of burn, sedate and proper analgesia should be provided. Patient is placed in burn unit, fluid resuscitation should be done. A Parkland regime which is 4 ml per burn percentage per kg body weight in 24 hours. Half volume in 8 hours, rest is given in 24 hours. This is an important point. This is Parkland regime. Then you have, it is the most common done, 4 per percentage burn per body weight in 24 hours. Every 24 hours. Then you have Gavelstone which is 500 ml per body meter square plus 500 ml per meter square. Fluids given are ringer lactate is the fluid of choice. Hartmann fluid, plasma and blood transfusion after 48 hours. Antibiotics give penicillin, cephalosporin, aminoglycoside, metronidazole, raised tube. Total parenteral nutrition TPN via CVP line for faster recovery. Raised tube also can be provided. Aspiration purposes. Local management, you have open method, you have closed method. Local management, open method, you have application of sulfur sulfasalazine without any dressing, commonly done in burns of face, head and neck. Then closed method, you have proper dressing done to protect the wound and reduce the pain. Dressing at regular intervals under general anesthesia using a paraffin gauze, hydrocolloids, fenestrated silicone sheet, Vaseline impregnated gauze, and biological dressing like amniotic membrane, synthetic biobrine. Then you have tangential excision with skin grafting done within 48 hours, done in patients with less than 25% burns. It is done in deep dermal bone. Dead dermis is removed till fresh bleeding occurs. Later, skin grafting is done. Advantages: you have reduced chance of secondary infection, reduces hospital stay duration, and reduces formation of hypertrophic scar or contracture. Then you have wound coverage. Once the area granulates, split screen grafting is done. For vital area, mesh split screen graft is used. If eschar is present, escherectomy, and if pseudo eschar, thickened burn skin due to repeated sulfasalazine. Pseudo eschar is thickened this thing. In face and ear, full thickness grafting, skin or flap is needed. Sculptured skin, sheets of skin, specialized skin technology useful in burns. Okay, sulfasalazine, you give sulfamylene and sulfonitrate. Sulfasalazine without any dressing. Paraffin gauze, hydrocolloids, tangential excision, you have skin grafting done within. Self-spreading efforts, later skin grafting is done. This is chance of secondary infection. This is hospital duration stay. Split skin grafting is done. Mesh skin grafting is done. Hysterectomy and so can burns in 80% of the cases. Then you have acid burns. Acid burns is a chemical burn with deep progressive tissue destruction. Types of burn: you have inorganic acid and organic acid. Inorganic: sulfuric acid, nitric acid, HCl, and hydrofluoric acid. Organic: you have carbolic acid and oxalic acid. Mechanism: it causes coagulative necrosis, precipitates protein and forms hard ester crust. Hard ester crust protects the underlying tissue for the burn. Treatment: you have water irrigation, calcium gluconate gel application at 15 minutes intervals, local or IV calcium gluconate injection, and continuous cardiac monitoring. And that's all for infections. Hand, I don't know, man. Honestly, I don't even want to do hand. Come back later. I'm more interested in doing venous more than anything right now. Arterial are also important. I can do this very, very fast. Yeah. Limb ischemia, yeah. Gangrene also okay. Somehow I can finish it off. Diabetic foot, okay. I mean, I knew it was going to take 3 hours to finish it. Venous disease is the main problem, bro. Fuck. I forgot such a big part of venous diseases. Lymphatic, I remember a little. Hodgkin's lymphoma, I don't know shit. Answers is okay. Bro, honestly, I want to go from behind now. From behind, it will take 3 more hours from now to finish the topics. So I'm thinking let's go from behind. Let's finish off breast and whatever it is. Then we go to thyroid. We are not doing. No need to do thyroid. Neck. Go to neck. Face syndrome. Salivary glands. And salivary glands also add a little bit. Little bit of oral cavity. Few topics. After that, we go to the cleft lip and cleft palate. Honestly, do in TB? I don't know. Cleft lip and cleft palate I know so well though. And mm, this is just 2 pages here. Okay, fine. I'll finish this. TAO, I'll do it later. I'll go to Venus. Venus, I'll do first. After Venus, I'll go all the way to neurological. Okay. I mean, from this point onwards, it's actually a lot easier for me. Only 2 more topics: a neck and a few other topics I'm not able to do very fast. That I'll do off, and yeah, you can check out in the next episode.